stethoscope. I can't believe it is.
I did.
I didn't bring any props. I know
renting.
you're always
I'm renting pops today.
okay. Fair enough.
Okay. Nice to meet you.
Can you slide around that? Got an extra bag here.
It's my,
This is,
this bag, but
Oh, this came.
my own
I see.
bag, yeah.
Yeah.
It's your-
Neurosurgery.
Well, I know nothing about neurosurgery. I can't even make small talk.
Good. I know a little, hopefully enough to get us both through.
Excellent.
You guys got bling.
Yes,
And
and you
bags.
have
I
a
love it.
swag bag.
Aaron told me to come and just.
That's it.
Yeah.
You will not be
Do I have to
disappointed.
speak also? Oh, I thought I was just coming to pick
You
up
gotta sing for
my
yourself.
swag, my swag
You
bag.
gotta sing for yourself.
I'll do that.
No
As
lunches,
far
right?
as swag goes,
Yeah, huh? Good. I need some more Carolina blue in my house.
hey, how are you?
Hey, thank you. Yeah. Thank you for
Hey,
the
Matt.
email.
Matt, good to see you again.
Anyway, I just wanted to
Thank you. My pleasure. Thanks for organizing.
Welcome.
It's good to be back. It really is. Yes, I do. Thank you.
Saw a wonderful presentation by kids in the foster care. Presenting their-
Isn't that nice?
It was
Probably very touching.
it was very
So where do you
touching.
spend your days?
I'm in the School of Medicine at the Population Health Science, which is we've got a little office downtown. But I'm actually moving down to adjunct status because I've got
It was, I feel like it was very
second little healthcare analytics
yeah,
startup that I'm working on. Great.
convincing for him.
Also downtown. So
Yeah.
my Duke blue ties are kind of being shifted to an adjunct status. I have a couple projects ongoing, but at the moment I have a lot of hats. As do you, but you have more important hats.
That's fun, and the companies must be doing okay.
Everybody's doing great. Yeah, I'm in a place where I have to. I need to
Things going on, so I want to add to her
You might have been
schedule.
Where's
protesting.
the company?
Yes.
We're downtown also. We have a little.
She actually enjoys working
But
with
we
you.
are.
She's a good lady. I like her.
Yeah, we've based on some of my. So I spent 2 years at Medicaid, and working on all that, and shockingly or not, we don't use our information as well as we could. Drive. So that's what we're working on.
Perfect timing as the crowd falls silent at exactly noon. Thank you very much for coming. Welcome. We are glad to see everyone. I wanted to let everybody know that we have 215 remote attendees today. So that is a fantastic turnout for this. I was moderately terrified before, now I'm plain old terrified. So we have 215 plus who are the people that are in this room. We're gonna have a great discussion today. I wanna have Becky come up first, Becky Mangini come up and introduce herself and give us some opening welcome remarks. Then we're gonna go through and introduce the panel. We'll do a little bit of housekeeping before we start that to talk about how the day is gonna flow. And we're gonna have a very productive, interesting couple of hours. Becky.
Good afternoon, everyone. It is in fact afternoon. I'm delighted to see so many of you here. Thank you for making time, particularly in these early days of the school year, to join in this conversation. I'm Becky Mangini. I'm the Interim Vice Chancellor for Workforce Strategy, Equity, and Engagement. And if I'm being honest today, I'm the understudy. Chancellor Guskovitz had planned to be here and really wanted to be here, but unfortunately was called to attend a funeral. So he asked that I send his regrets and his thanks to the panelists. But he told me, as we were talking a little bit about this event, that he and Treasurer Falwell go way back, back in that they passed some concussion legislation back when Treasurer Falwell was in the General Assembly. And certainly he knows the other panelists as well. So he asked me to send his thanks. And his thanks to all of you and the 215 of you who are participating remotely for engaging so meaningfully in a conversation that's really important to all of us. It's no surprise to any of us that healthcare is complex, and it's not a secret that the costs associated with it are growing. In North Carolina, these costs, as I understand it, have been distributed across benefits providers, healthcare providers, employees, and employers for some time, and likely a whole bunch of others as well. At some point, however, for many of us, the fine print gets lost in the face of realities of copays and rising premiums. Events like this one provide a forum for all in our community to come together, learn, ask questions, and exchange ideas. And we're incredibly grateful that our sponsors are kicking off this event at the start of a new academic year with a program that hits decidedly close to home for so many of us. While a solution that addresses many of the network concerns you all raised related to the state health plan have been found, we're particularly eager to hear more about the ideas behind clear pricing and what the resolution now in place means for coverage, for open enrollment, and for ongoing transparency in pricing as it's paired, most importantly, with top-notch medical care. I'm excited that our panel today includes Secretary Falwell, as well as colleagues from UNC Healthcare, elsewhere on campus, from UNC System, from the UNC Retired Faculty Association, and from that other blue school down the road. I expressed a broad array of thoughts and opinions from a whole range of perspectives, and for the event to provide yet another way for each of you and all of us to share with these decision makers the sorts of things that are important to you as you think about your own health insurance coverage and those you opt into in support of your families. Thank you once again for being here today. Please join me in thanking both our sponsors, the Employee Forum, the Faculty Council, and the Carolina Black Caucus, and in welcoming Jeffrey McQueen, who also serves as the Employee Forum parliamentarian, back to the stage.
All right, housekeeping a little bit. So how's today going to flow and run? What are we going to actually be trying to accomplish? Taking a step backwards, one of the things that I have been most gratified about for working for this university has been the way that we are able to talk, that we are able to have dialogue and discussion, the way that we are all pulling in the same direction for solutions. We are not at odds with one another. We're all trying to get to the same spot. Quality health care at affordable prices for our people. How we get there, I don't know. We're not going to solve that today. We're not. There's lots of people working on this all the time trying to figure it out. What we can do today is ask questions, get comment. But what we're not going to necessarily do today is we're not going to argue about anything because that's not going to get us anywhere. We're not really going to relitigate the past, which is sort of an exercise in futility to begin with. Forward. Let's look forward and see what we can do, what kind of questions we can get answered today. This is a fantastic turnout, fantastic group. Anybody that wants to sit down in the back, please have a seat. It's absolutely fine. We got plenty of seats still available everywhere. I want the panel to introduce themselves in a little bit different way. And this will probably be my first and last time actually moderating a discussion like this because I don't necessarily do things exactly the way that everyone else might do them. But I'm much more interested in people and who these people are. I think that's a reflective of the Employee Forum values. We are about people and staff. I just want to hear from each of the panelists, who the heck are you? What the heck are you doing here? And what's your role have to do with healthcare? Because believe me, as I started to do my research about this issue, I was woefully ignorant about how my own healthcare functioned and worked. I simply had no real idea about it. What I think I will reiterate again, though, is I found that everyone on this panel is trying to make things better. We just have different ideas about how to do that, and that's okay. It's absolutely fine. All right, I've said more than enough. All right, we're going to start. Spoiler alert with Treasurer Falwell. And he's going to start. Everyone else is going to go down the panel after him. Thank you.
Is this my 5 minutes or my 10 seconds?
We'll give you your whole 5 minutes. I will not claim any back.
Thank you. Thank you for having us. I had several come up to me as I was getting prepared and thank me for being here. And I always go where I'm invited and where I feel like I'm welcomed. And I've always felt that way on the campus of UNC to talk about these important issues. Yesterday's sermon at our church at Ardmore Methodist was about fear. And the analogy that was used to give the sermon really had something to do with the stethoscope, ironically, since we're talking about healthcare today. And you might remember back when the first time you saw one of these in your life. And most likely, some doctor took the earpieces off of their ear and put the earpieces on your ear so that you could hear what was happening here. I hope today that you get not the tone of what I'm saying, but you need to hear the message of what I'm saying. Because I'm probably going to tell you some things that you were unaware of that have been going on with your state health plan for a long period of time. My wife is a tour guide at Old Salem, and what that means is that she's the cutest 250-year-old woman you've ever met in your life. Because when she goes to work every day, she dresses up in the period uniform of 250 years ago. That's her job, and she demonstrates to school kids all day. In addition, she's a musician and an artist and a singer. My point of bringing her into this conversation is that anytime my wife does anything for you, you can see it or you can hear it. In many instances, what we're going to talk about today is the invisible. Something you can't see, something you can't hear, something you can't really wrap your arms around until something really bad goes wrong. The chairman of the board of BB&T, Kelly King, always admonishes us to focus on the why we're doing something, and then we'll figure out the how. So over the next few minutes, I'm going to tell you the why we're doing what we're trying to do with the state health plan. Everything that I say, as you can see by all these stacks of papers, can be documented by some outside source other than the words actually coming out of my mouth. So let's go to the why very quickly. 7 years ago, the state auditor, now let me stop because anytime that I use certain words in an audience, half the people's brains shut down. So I'm going to go ahead and get this one out of the way. Republicans, independents, and Democrats. There's no Republican, independent, Democrat money in the state health plan or at the treasurer's office. It's all green. We're keepers of the public purse. This is your money, and we're here to exercise a loyalty and duty of care to it. So Beth Wood, the state auditor of North Carolina, said 8 years ago that your state health plan is at risk for overpaying medical claims because the plan auditors do not have access to the vendor contracts and cannot verify that you or the state is receiving the proper contractual discount. Why should this matter to you? The reason it should matter to you is that not only this state auditor said this, but the previous state auditor said the exact same thing 11 years ago. Your state health plan is spending over $3 billion a year for healthcare and pharmaceutical benefits. To put that in context, that is more money than gets appropriated to run all the public universities of North Carolina. That is more money than gets appropriated for all of the justice and public safety, from the deputy sheriff to the Madam Chief Justice of the North Carolina Supreme Court. This is a major amount of money. People can identify with the universities, they can identify with justice and public safety, but now there's $3 billion sitting that's being spent on something, and we don't know what we're getting for that. Secondly, the size of this plan. This plan has 720,000 participants in it. What should that mean to you in context? That is almost as many people than work for these three companies in the United States combined. Warren Buffett's Berkshire Hathaway, Jamie Dimon's JP Morgan, and Jeff Bezos' Amazon. The buying power of the plan that you're involved in has as much buying power as JP Morgan, Berkshire Hathaway, and Amazon. And it's frustrating to me. You should be outraged at the fact that you're involved in the plan, which is the largest purchaser of something in this state, not just healthcare, but pharmaceuticals, and we're not getting the best possible prices. Also, 8 years ago, Bill Gates, in a conversation with Warren Buffett, said the single biggest threat to public education. Think of how each one of you would individually finish the sentence. The single biggest threat to public education. The single biggest threat to public education is how states account and fund for their unfunded health care and pension, ongoing funding, and unfunded liabilities in the future. Bill Gates, the greatest philanthropist of our lifetime, could have finished that sentence in any way that he chose. But he chose to focus on something that's really happening, and it's really happening right now. The other part of the why is that the state health plan is going to run out of money in 2.5 years. The reason it's going to run out of money is that not that your utilization is going up, you're doing a great job on utilization, but the cost of everything is going up. And the way that that's manifesting itself in many different ways, but the fact is that whether it's the governor's budget or the legislature's budget, this plan, your plan only gets funded at a 4% increase. Raise your hand if you think that the healthcare cost or the pharmaceutical costs are going up 4% or less. Nobody believes that because it's not true. Our healthcare and our pharmaceutical costs are going up more than 4%. But we're only getting funded at a 4% rate, and we have to live within our budget.
I'm going to give you a bit of a warning on time because we're going to be moving forward.
Thank you. So last summer, we tried to find out what we were supposed to pay for healthcare, going back to what the state auditor did. So we sent a request to UNC Healthcare and said, we know what we're spending. We're trying to figure out what we're supposed to pay. I know how energetic you are, so I'm getting ready to show you a price list that was sent to me as the state treasurer of what an appendectomy, a tonsillectomy, or knee replacement, or anything else that UNC Healthcare offers is supposed to cost. This is what was returned. No one wants you to know what the price of healthcare is.
And that's a perfect place to stop because we're going to have more time to talk about that exact issue. So we're going to move on to the next panelist. Thank you.
Very good. Thank you. Thank you, Treasurer Forwell. I'm Matt Brody. I'm the Senior Vice President for Human Resources at the UNC System Office. Part of our role at the System Office is to serve as a liaison between the 17 campuses, the university system, and the state health plan. So we clearly have a very substantial interest in this issue. I will tell you, I've been at the System Office for 5 years. I was at this campus for 13, primarily in human resources roles. And this is not a new discussion. I've been talking to employees about our state health plan for about 18 years. The issues have been very similar, increasing out-of-pocket costs, very, very high, if not unaffordable, dependent premiums. And quite honestly, in some ways, not that I'm lobbying for an increase, but very artificially low individual coverage. Many years it was actually free. These are not issues that we're just struggling with today. This has been something that's been on the forefront for a number of years, as has been the fact that we have many lower paid employees where the percentage of their premiums as to their income is too high. So those are long-standing issues. I will certainly say that when it comes to the cost effectiveness of healthcare and making sure things are more transparent, and honestly, when we talk about transparency, it means you and I being able to understand when a bill comes, what it means, what the insurance company pays, and being a good consumer. Those are challenging for all of us. Those are not issues that are unique to the state health plan or state government. They're issues for all of North Carolina. They're issues for our nation. So I do applaud the treasurer and our state health plan colleagues for their efforts to enhance cost effectiveness and transparency. I think those are unquestionable goals and certainly should be supported. But I will tell you, as the Chief HR Officer for the UNC system, I also have an interest in assuring that while we attempt to solve these very difficult and real problems, that we as employees don't get caught in the middle of that. And I've heard from many employees over the last few months as this effort around the clear pricing and the network, the state health plan network, have come to the fore, that employees are very concerned. We've had even folks be very scared about losing access to long trusted providers and them all of a sudden being out of network. So I think we have a tension here. These are very real issues on the national stage, and certainly for the state of North Carolina that must be solved. On the other hand, we need to make sure they're solved in a way that doesn't disproportionately impact our employees. And those are the two messages that we've tried to convey in our conversations with key stakeholders, including the state health plan. I will say that I think the key to this is partnership between all the parties, between the employers who have employees covered by these plans, between the plan administrators, and between our healthcare providers, our local physicians, our hospitals and healthcare systems. And we're all going to need to work together to figure this out. And we need to get this figured out in a way that doesn't end up, again, affecting our employees in a very negative way. And that's really from the UNC system perspective where I come at this. We have 46,000 active employees. As the state treasurer said, there's over 720,000 people covered by this plan. So although we're a key participant in this plan, we're in relative terms a small number of the total people that are covered. So we're one of a vast number of individuals that are impacted by this. But our interest is in our 46,000 employees and our retirees continuing to have access to in-network coverage and being able to rely on the local providers and hospitals that serve them today. And I hope we'll have some good dialogue about making sure that those interests are protected. I'll yield the balance of my time to our next speaker.
Thank you.
Thank you. Good afternoon. My name is Shana Hill, and I'm the chair of the UNC Employee Forum. We are the advisory body to the chancellor representing 8,600 staff. I do not claim to be an expert on healthcare, but I can say that my role has given me a unique perspective on staff experience with their healthcare. Thank you for allowing me to share my experience, strength, and hope from my view as the chair of the Employee Forum. One employee shared with me that for the past several years, she has had to make the decision between health care for her children or health care for herself, often choosing not to visit her health care provider for yearly checkups and putting off procedures for herself. Another employee shared with me that she is filing bankruptcy due to staggering medical bills. This is an employee. More than one employee shared with me that they are leaving UNC because the cost of family coverage is prohibitive. Another employee told me that she doesn't insure her family through UNC, but through her spouse's insurance because it is actually affordable. And lastly, an employee shared with me that he had a serious but treatable issue recently that cost him all of his yearly savings. There are many more examples I could share, but this gives you the basic idea. The strength I would like to share is that these amazing employees, all 8,600 of them, are doing an outstanding job managing programs, processing applications, running technology, and countless other tasks, and they deserve better. The hope that I would like to share is through this forum, and hopefully many more like it over the next year, we can come up with a system of healthcare delivery that will be affordable and more in line with UNC salaries. We clearly have the brain power, as many of us hold UNC degrees. Let's put that brain power to work.
Thank you, Shana. Good afternoon. My name is Matt Ewand. I'm a faculty member in the Department of Neurosurgery. I came to Chapel Hill in 1997, and in those 22 years, my wife and my 3 children and I have all been state health plan members. I am a practicing neurosurgeon. I specialize in helping folks who have brain tumors. I'm also the chair of the Department of Neurosurgery. And in the healthcare system, I hold the role as the president of UNC Physicians, which is the umbrella organization over our 2,500 or so physicians. I thought it might be useful just for a second to remind you all of the overlap and the differences between the healthcare system and the School of Medicine. I'm a School of Medicine employee, and when I'm over in the School of Pharmacy with partners doing research, I'm really working in the School of Medicine. But when I'm operating in the hospital, I'm working in one of the facilities, I'm working for the healthcare system. We have 14 hospitals in our healthcare system, from Hendersonville in the west down to Jacksonville in the east, and we care for about 1.4 million North Carolinians. The mission of the healthcare system is to reduce the suffering and improve the health of North Carolinians for this generation and generations that follow. This generation through the care we give, and future generations through the research we do and the education we do. We talked a little bit about the invisible things you can't see. So here are three maybe invisible things about the healthcare system that you didn't know. We do about $500 million, $500 million a year in uncompensated care across our healthcare system. We provide about $40 million a year for rural hospitals in our system to ensure that there's care in local communities outside the Triangle. And we provide about another $40 or $50 million to the School of Medicine to support the research and education missions. You can't buy stock in UNC Healthcare. We don't pay a dividend, but we do promote this mission, and we do support these really important things throughout the state. The state health plan is very personal to the healthcare system. We have somewhere between 13 and 16,000 people covered on the state health plan. So when we sit and talk about the well-being of the state health plan, it's not just as healthcare providers. For many of us, it's our own personal health insurance. So I think we have what they call skin in the game. We agree on many things about this. We agree that healthcare has to be more affordable, and we're already working to do that. We believe in access, regardless of how much money you make or where you live or what your past medical history is. You should have access to quality healthcare. We believe in transparency, which is why we put forth in late June a plan that I'll discuss in a minute that includes a pledge to support transparency, and that's available on our website to anyone who wants to see it. There are some things that we think should be done in a different way than what's been said by the state health plan. The plan that we put forward aims to reduce the total cost of care, to increase quality, to improve transparency through our transparency pledge, to be sure that those changes don't destabilize healthcare throughout our state. We worry about the care of all 10 million North Carolinians, and we feel a responsibility to make sure that a change in one area of the system doesn't cause terrible ramifications for other folks. And then finally, we strongly support a sustainable state health plan for me and my family, for you and your family, and for all the 700,000 people. Our plan is based on healthy-based care. It's our belief that healthy people with healthy habits will spend less money and have better lives. And so much of what we're driving at is not reducing the cost of each incidence of care, but improving the overall health of all of the people that we care for. And so I'll give you an example of where that partnership is already working. We provide care for a health plan which is called Blue Value, which is the individual mandate or the ACA or the Obamacare plan in the Triangle. And the last 2 years, that plan has had a reduction in premiums, the first year by 20%, and then this year by 4%. So working in a value-based system aiming to reduce health can reduce costs. We think there are many areas of agreement among the panel, and there's also some difficult issues to be laid out, but we welcome the opportunity today, this afternoon, tomorrow, and in the weeks and months that come to really get good answers in place. Thank you.
Hi, everybody. I'm Aaron McKeithen. Please don't boo when I tell you that I am a professor at Duke in the School of Medicine. Because, no, don't do that. Don't do that. My ego can't take it. I'm a two-time Tar Heel, so you can cheer for that. I was an undergrad here and then a PhD in healthcare policy or public policy analysis just down the road there. And so I'm pleased to report I have a Michael Jordan poster on my Duke wall. So I'm doing my best to be the missionary in a dark blue land. So I'm here because I've been studying healthcare policy for the last 15 or so years. Here in Chapel Hill, I tried to get a lot of people excited about public employee and retiree health plans when I was writing a dissertation, looking across the very issues that we're dealing with right now in other states and how other states handle these kinds of issues and nationally. And so as I see some of the questions come in from folks who are dialing in, a lot of them are focused on the practicalities of how to get insurance and what's going to happen to my plan next year and the like. I'm probably not your best speaker for that, but when we get to the discussion, I'd like to make some comments on the Clear Pricing Project and what I think represents a lot of the commonality across a lot of the commonality across the panel. But I'll also warn you, I have a few things I'd like to inject that I think will annoy at least somebody in the room about how the structure of the plan is set up and ways that we can get it in a long-term fiscal kind of sustainability. I'll mention this thing, yeah. I'll mention at the outset that and having been a board of trustee on the state health plan, I commend the treasurer for thinking about the fiscal sustainability of the plan. It's an important objective. 20 years ago or so, maybe 15 or 20 years ago, it was known that the value, the economic or the actuarial value of the benefit, particularly to future retirees in the plan, we did not have the money set aside for that in the state. The legislature wasn't creating a savings account that was sufficient to paying for it. That's not anyone's fault in this room, but it is true that there is the need to think about how we're going to pay for this thing in a world where states have to balance their budgets and the like. And while healthcare is complex and it's big, 20% of our nation's GDP is on healthcare, I think it helps us in conversations like these to try to make it as simple as possible. So how are we going to pay for that? There's only a few options. If you distill it down to a few core options. Option one is keep people out of the benefit. Don't restrict eligibility. No one wants that. I don't think that's being proposed, but that's one way to save money. A second one is to restrict what we're covering. Take the actual benefits and decline coverage of certain things. And I don't think we're talking about that today. A third is to shift more of the burden of the rising costs to consumers. And there's a couple ways of doing that. One is to raise premiums, which has the effect of distributing across the entire insured pool, presumably smaller amounts of money shared widely. Another way of doing it in that bucket is to raise out-of-pocket costs, and that has the effect of effectively taxing those who use care more, so making it more expensive if you're ill. And I think the state health plan grappling with these issues over the last 10 or so years has done a lot of that. And those of you who benefit from the plan know that, and you feel that in your pocketbook every day, particularly those on the low-income side of healthcare. I often wonder, and we don't have the data on this, how much of a teacher's increase in compensation over the last 10 years has been eroded because healthcare costs have effectively offset any gains. Well, we don't know the answer to that because there's different departments that cover employee wages and the health plan, but it's a noble question, and it's an important one as we think about, are we going backwards or are we going forwards in our total compensation? So this is an important issue, and it's really hard to push more money either in premiums or in cost-sharing obligations to consumers, retirees, and their families. So the final way is to think about the total cost of care. And I think there's probably some alignment across the panel here that's really the place to focus. And I think probably the biggest disagreements will be around how we do that. I have a different approach in mind than the Clear Pricing Project program, but again, the spirit of articulating that we actually have a lot more in common in identifying the problem here than we have differences. I think it's important we'll get into those details later, but I'm thankful, even with seeing your heads nodding, that this is affordability and sustainability of the plan is something that we can all agree on. The question is how we get there in a way that maintains the value of the benefit and takes care of the promises that we've made to public employees, retirees, and their families. So more details in a little bit, for me at least, on those issues, but that's why I'm here.
Thank you. I'm Donna Falvo. I'm president of the Retired Faculty Association. When I was working, I was with the School of Medicine. At the time, my department was called Rehabilitation, Counseling, and Psychology, and it's now called Clinical Rehabilitation and Mental Health Counseling. Everything changes. Accessibility to affordable quality health care is, of course, an important issue for everyone, regardless of age, regardless of employment status. With the current state health plan, faculty, employees have been assured that their needs will be met, that there will be benefits to take care of their health care needs. But with potential changes to the health care plan, there's been a lot of uncertainty, there's been a lot of confusion, and it's caused some anxiety about what this means to individuals in the future and how those changes might in turn affect quality health care and access to health care. Now, for the people I represent, the retired faculty, most are on Medicare or secondary health care plans. And so the current changes that are being proposed or have been proposed in the state health plan at this time don't appear to affect the people that I'm representing. However, because those concerns that we now have with the health care plan grew out of, as we've heard from our other panelists, the state's ability to keep up with rising health care costs, the rising demands for health care. Retirees really can't be complacent, feeling that their benefits are always going to be there and that there's really nothing to be concerned about. And let me tell you a couple of reasons why. First, since 2010, when the baby boom generation came of age, so to speak, a number of individuals, more and more individuals, have become eligible for retirement and Medicare and secondary plans, and that number continues to increase. In addition, we know statistically that individuals are living longer, many growing into older age, and so the needs for Medicare and healthcare plans will gradually increase, and the numbers have increased so that they aren't the same as they would have been 20 years ago, as an example. Now, of course, retirement doesn't mean automatically that people's health care needs increase, and nor does aging. Aging isn't synonymous with chronic illness or disability, but if we look at things statistically, we do know that the older individuals become, there is a greater chance of developing medical conditions that are going to require increased health care. Excuse me. Now, for retired faculty who have been assured that they have a stable health care plan that could meet their present needs or their future health care needs, any changes to that plan, as you can imagine, are going to be pretty anxiety-provoking, especially when the consequences of any proposed changes aren't really clear and people aren't really sure what all those proposed changes might mean. There are no easy solutions. These are real issues, and there are issues that we really can't ignore. We have to face them. We have to deal with them. Today's forum is a wonderful opportunity for discussion and dialogue. As I said, there are no easy solutions, no easy way to solve the problems, but until all the stakeholders who are affected are able to be involved in the conversation and their issues and their concerns adequately addressed, an effective, workable solution that's going to benefit all really can't be addressed. And so it's wonderful that this forum is occurring, and hopefully this is the beginning of much discussion and dialogue for the future.
Thank you all panelists very much. I appreciate those statements. I think that gives everybody kind of a better idea of who you are and where everyone is coming from. And again, I'm going to beat this dead horse continually, that you can see from the statements here, everyone's pulling in the same direction. Everyone's trying to arrive at the same place for our healthcare. So it's just a matter of how do we get there and how do we start addressing the problems. And that leads me to my first question that was probably the most common question that we got from folks is, where are we at today? What happens when open enrollment starts? What are my options going to be for that? That's as much a process question as it is anything else, but I think that people absolutely, there's still some confusion out there about where we are right now in terms of our healthcare with the Clear Pricing Project, and what differences, if any, are those going to make in the coming year. And anyone can start. If the treasurer would like to start, anyone can start. I don't want to put anyone on the spot for being the person who has to answer that question. It's a process question.
Thank you. When I became the treasurer 2.5 years ago, it took 51 clicks to get through open enrollment. I could not personally get through open enrollment as the state treasurer of North Carolina. Now, that says a little bit about me, but after hearing a lot, see, Jim Valvano said we're supposed to laugh a little, cry a little, and think a little every day. So now we got the laughing out of the way. But the fact is, it was too complicated. Now, open enrollment is less than 10 clicks. Do you smoke? Yes or no? Do you agree to cessation? Yes or no? Which plan do you want? Yes or no? We're done. This whole saving and wrong terminology, taking a picture of it and making sure it was properly saved was a crock. We have people on this plan who teach kids, who protect us from criminals, who serve us in all kinds of ways. They don't have the damn time to sit there and go through 51 clicks, take a picture of something, and then when they go to the doctor in March, they realize they didn't sign up properly. Now, we've partnered with Matt because we listen. And so one of the first people that I went to when we were trying to solve this problem was our biggest customer, which is you. And actually, this is one of your largest complaints, right? And would you like to say if it's a complaint anymore? It's still a complaint?
No. The enrollment's good. Now you need to work on dependent premiums.
Okay. Glad you segued that. This plan is very complicated. This is actually what happens anytime anybody open enrolls. This is actually what happens to every time you open enroll or have a claim. Back in the old days, and I'm going to take a little extra time, and I'm sorry, but these people deserve to know this information.
I'm not going to keep anyone
Okay.
from information,
All right.
but we want to make sure the whole panel gets a chance to talk as well.
Back in the old days, Blue Cross had the insurance plan, Blue Cross had the Medicare Advantage plan, Blue Cross had the prescription drug plan, Blue Cross had the population health management plan, Blue Cross had the open enrollment. They had everything. This was pretty simple. When I became treasurer, every one of those things that I was just talked to you about is in a different, with a different company. So it's not as easy as it used to be. So open enrollment is coming into place in November 2nd. Why in November? The reason is that we were trying everything that we could to save the plan and to save members over almost $50 million in copays and deductibles for next year. We were doing everything we possibly could not to increase anxiety, but to get rid of secret contracts, push the power out to the consumer, and lower cost. We were boycotted. We'll hear more about that later. We were boycotted by all the major hospitals, including the one that's represented here, even after being offered 100% profit. So to answer the question, open enrollment is going to start on November 2nd. And it's going to exist for, I think, 17 or 18 days. But it's going to be a lot simpler than it used to be. Open enrollment used to take place actually back in the spring when you were trying to make family decisions about open enrollment and it wouldn't synchronize with your spouse as you were trying to determine where your family went. So we've done a great job with that, and that's why open enrollment is happening when it's happening this year. Our only goal, in case I'm not given the mic anymore for the rest of the time, is simply this.
I think you might get it again.
This is what happens to healthcare. This is the consumer, and this is the payer. Unlike everything else in your life, whether it's Harris Teeter or a gas station, the consumer really never knows what the payer paid for healthcare, and the payer really never knows what happened to the consumer. This is the only aspect of your life where the purchaser, the consumer, and the payer are not side by side. And all we're trying to do with clear pricing is get rid of secret contracts, push the power to consumer and lower costs. As far as the retirees, as far as the increase in anxiety, this never impacted the people on Medicare Advantage who are on the United Healthcare product. Never. So anybody who was increasing the anxiety regarding our retirees are people that were willfully putting out misinformation, because it never affected the United Healthcare, and that's 147,000 participants. So open enrollment is happening in November. You'll get an open enrollment book. We continue to work on the technology to make it simpler, and that's exactly what's happening this fall.
Thank you. Let me add that the treasurer is exactly right. The mechanical process for open enrollment was extremely difficult. We got complaints from many employees along with the HR offices, and worked very closely with the state health plan folks to reduce the number of clicks dramatically. So this is, with due credit to our state health plan colleagues, an immensely simpler process for all concerned, and we appreciate that very much. I think the most notable thing, the treasurer has noted the timing of the open enrollment process. I think the other key point, which is critical and which has been the question that we've received from many employees, is that in terms of providers in network or out of network, that when you go into open enrollment this year, the state health plan has informed us you'll be able to choose from the normal provider network, which is the Blue Cross Blue Shield provider network, I believe, as well as the clear pricing, the new clear pricing network. So you'll have a combination of networks. The net result this year is that there'll actually be more potentially providers that are available across both of those networks. I think the critical point and the thing that we were most concerned about is disrupting provider relationships for our employees, whether it's your general practitioner that you have your day-to-day relationship from, or local medical groups, and especially hospitals and healthcare systems where you seek advanced care. Our biggest concern was that there would be less choice. And that's, as I spoke to earlier, we're all for positive change in terms of increased cost effectiveness, but we need to make sure that our employees don't get less choice in the process. And I think we can assure that during this open enrollment period, that will not occur. So I will pass the mic now down the road.
Anyone else like to comment on the open enrollment process or plan? All right, very good. Thank you. I think, yep, sure.
Matt is exactly right. There are 28,000 providers in North Carolina who signed on to clear pricing, which means they're willing to tell you what they're charging you. You're going to know what they're charging you. You're going to have the power as the consumer to figure out where the best value and the lowest cost for healthcare is. Those people will exist inside this plan going through open enrollment. And because we were boycotted by most of the hospitals in North Carolina, we have taken the existing contracts with those hospitals, we've rolled it in under the umbrella of the North Carolina State Health Plan. I don't want your eyes to glaze over when I use that term. There's never been something called the North Carolina State Health Plan before. This plan has never, ever taken advantage of its buying power that I described earlier. So my point of saying that to you is that we are going to exalt, and we're going to partner, and we're going to work with the 28,000 people who said yes. By the way, some of these doctors are going to be, and providers are going to be getting less money, but they know that this program is unsustainable. So this is very important for you to know that all the hospital contracts that currently existed with Blue Cross Blue Shield, even though they're secret and even though we're paying more, those are folded in under the state health plan. So it should seem seamless to you as a consumer, except that in 28,000 instances, you will have the power to consume. And we're going to be telling you more about that in the future.
Here, please.
So, hi, everybody. I'm going to say a few things that are sure to displease virtually everyone. So let me get this out now, and let me just sort of give you my perspective on this. So, and I'm going to ask the treasurer to confirm that I'm thinking about this right in terms of the actual program. But as I understand it, the clear pricing plan says to mental health professionals, primary care providers, and certain very small critical access hospitals in rural areas, you're getting a pay bump. For virtually everybody else, on average, and again, the provider reimbursement is different from provider to provider, community to community, for reasons we can go into later. But for virtually everyone else, the fees, the prices paid for services are indexed to Medicare, the federal Medicare program, and the net result of that, if everyone participated in that, would be cost savings. You'd have some getting more, most getting on average less than whatever they're getting today. All right, so that's, am I, okay, we're good there. Okay, so a couple of comments in terms of with the desire to get us to something that I think can be constructive and valuable as we keep getting into the details. I do think there's a lot of agreement. As I think about North Carolina, we're really just a proxy for the country. In some ways, the issues around affordability are not unique to the state health plan. And they have a lot to do with the structure of a local healthcare market. So I'm going to ask you to just imagine two types of communities in the state. This is a little bit over exaggerated, but I think it's mostly right. On the one hand, there are certain parts of the state where there's a single hospital or a single health system. Sometimes, like my home in Watauga County, there's one hospital because it's a pretty small place. They don't need one hospital. In other parts of the state, hospitals have been buying other hospitals, and they've been becoming bigger and bigger, down to becoming a dominant hospital. Why do they want to do that? A lot of reasons for it. One of them is they have the ability to tell an insurance company or a health plan like ours, or the one that we're talking about today, we decline to participate in anything that will lower our rates. So as I think about what just happened, was played out over the state, on the one hand, there's roughly half the state health plan members are in parts of the communities where there's one hospital, and they have the ability to basically just say, no thanks, I don't want to take less for delivering the same services. In other parts, so there's really there's not much competition there. On the other hand, about the other half of the state health plan membership lives in communities like this one, where there are multiple health plan options, multiple hospitals and health systems that presumably compete. We see that in Charlotte. There's Atrium and Novant. Here in the Triangle area, we've got multiple hospitals and systems. Again, outside of the context of state health plan, what we typically don't see is a lot of signs that there's healthy competition between those systems based on price. Why is that? Why don't they compete? Why don't multiple systems compete on the basis of price? Well, it's complicated, as everything in healthcare, but the way I think about it is we haven't asked them to. We haven't asked them to compete on the basis of price. Why? And this is the part where this will start to cause you to not like what I'm saying. Partly because we like an open access, one-size-fits-all health plan that includes every provider. When you have a model like that, and there are exceptions to that, when you have a model like that, there's really not a threat to Duke or UNC or Wake Med that if we don't get our prices at some level, we might not actually be in the network. And so in healthcare, we haven't really used the power of narrowing the plan design such that we use our data on cost and quality, and we say we only want to offer to our employees and retirees a number of provider options that is consistent with quality and total cost of care or patient experience. We don't do that today. So as a result, when the clear pricing program comes along, for those communities where there's only one hospital, it's not surprising at all that they're going to decline to participate in something that's going to pay them less. And for other parts of the state, it's also quite easy to decline because the plan design includes virtually everyone. But my question to us as we think about the future is, why do we think we need 50 different orthopedic practices to choose from when maybe there's some that are better than others? And I think the treasurer has been trying to use the data we have to make clearer to folks which providers deliver high value care at lower overall cost. And we have a long way to go in getting there. But my view is it's hard to think about just cutting prices without also thinking about the structure of the design of the plan option. Now, this gets complicated and controversial because the legislature is reluctant, or has been historically, to create different types of plan designs in different parts of the state. If you're a teacher, whether you're in Watauga County or in Wake County. And so why give Wake County fewer or different choices than you'd give in Watauga County? And those are big, hard things to decide. Again, that sort of, they're outside of the context of the state health plan. And so I think as we think about that last category I mentioned a few minutes ago, how do we get the total cost of care down? I really like the constructive proposals that folks like UNC have been putting forward around, let's go on a diet and exercise plan together. Let's think about what total cost of care would look like 5 years from now or 3 years from now. How do we work toward holding the line on the total budget that we spend overall? Because healthcare is super complex. It's hard to just push a button, an easy button, and say, we're going to lower prices and that's not going to have some impact on access or quality. So I think as we think about these ways of keeping the total cost of care down, I think we could be having conversations about what the plan design itself looks like. Do we want to imagine a plan design that helps the market do what markets typically should do, which is compete on the basis of price and quality? The way to do that is just what was referenced earlier. When Blue Cross Blue Shield, I think it was last year or the year before, came out with this insurance exchange, this Obamacare exchange program that did not include the other Duke down the road. Guess what happened overnight? Costs came way down in the plan. The big provider who was in that network got paid, got a lot more volume. The provider that didn't is now thinking, next time I have a chance to get back in, I want to compete on the basis of price and quality. I want to get back in that network. So these are healthcare. It's really hard to just push a button and call price reduction and think that's going to do it. We've got to be thinking about the combination of what does the benefit look like, and that does mean sometimes thinking about the scary prospect of switching doctors if your plan design doesn't include your provider. There's a lot of technical details to work out, but in general, partnering with big systems and hospitals and competitive markets around the idea that they want to be committed to total cost of care reductions, or at least a budget where they can save money if they come under the budget, and where they can gain if they do better or they're sharing the losses if they don't. That's a phenomenon happening nationally with some really good results to show. Nothing would happen overnight. These require multiple years of concerted, constructive, respectful dialogue around these kinds of things. So I've taken longer than I probably should have, but I wanted to just at least get out on the table the fact that in healthcare, and I think everybody knows this, it's really hard to think about tackling one dimension of the overall healthcare economy without thinking about multiple components together over time.
Thanks, Aaron. I'll just make 3 quick points, or 2 points an example. The first is, last year on open enrollment, that day I had 2 surgeries to do, and then I had to enroll me and my 3 kids, and that was the hardest thing I did all day. So I made a note for November 2nd, no surgery for Matt Ewan, so I'm sure it'll be easier this year, and then I'll be able to go see patients. I did want to comment on the response of UNC Healthcare to the state health plan's reference-based pricing proposal. We did, I don't like the word boycott. We responded very thoughtfully with a proposal, and I did take the liberty of highlighting the part of the proposal that talks about our price transparency pledge. It goes on for a whole page talking about our commitment to price transparency. And again, this is available to all of you. So I don't think we boycotted this. I think we responded thoughtfully to say that we thought there was a better way to achieve these aims. I'll give you one quick example of this that was shared with me by my colleague Mark Gwynn, who runs one of our ACOs with Medicare. We had a patient in one of the counties outside the Triangle who had visited the emergency room 30 times in a 6-month period. Let's say each visit was $10,000. That would be $300,000 to care for that patient. If you were to simply say we have to reduce medical spend, so let's cut the price by 50%, that would mean in the next 6 months, the patient would go to the emergency room 30 times and would only cost $150,000. That's still way too much money. And so what Dr. Gwynn and his team did, because we were using a value-based approach, we're looking into why certain patients are having trouble. We found that that patient had behavioral health issues. Within the practice where she was cared, we had social workers and mental health professionals who could work with that patient. And that patient got better, and their mental illness got better, and they visited the emergency room twice in the next 6 months. And so that's a much less expensive way. And most importantly, and left out of the story unless you think hard about it, that woman was well and better, and her quality of life was better, and cost was reduced. So a process that really aims on finding the drivers of cost, making people healthy. Yes, it's hard work. Yes, it takes longer to do. Yes, it's harder to explain. But the only way we're going to really bend the cost curve is to make all of us healthier and to try to put more of our efforts into prevention and heading off trouble instead of trying to fix things when they go wrong.
You ready? All right. We do. This actually, all of your comments have led us perfectly into one of the most common questions I've gotten, and I'm getting online as well, is what's coming up? What is the next year going to look like in terms of negotiations around this same issue? It sounded like that we had a pause in this for the coming year, but what efforts are going to be going on in the upcoming year on this same issue? And Mr. Treasurer, you can start.
Well, as I said earlier, our plan is being budgeted at a 4% increase, and our healthcare and our pharmaceutical spend is going up more than 4%. I'm sorry that the Clear Pricing Project was boycotted by most of the major hospitals in North Carolina, because what we were going to do with the savings of that is we were going to cut family premiums. Over the last 2 years, even in spite of the fact that the amount of money coming into the plan didn't keep up with the increases in the plan, we froze family premiums the first year I was the treasurer, and we froze family premiums the second year I was the treasurer. Our goal for next year was actually reduce family premiums. Let me personalize this for you. Maybe not the people sitting on this stage right now, but a lot of people who work on this campus are having to work 1 week out of the month to pay the family premium. These are the invisible. So they're making a choice between mortgage and healthcare, food and healthcare, energy and healthcare, living their life in healthcare. I advocate for everybody. I have a loyalty and duty of care, but especially those people who are having to work 1 week out of the month to pay the family premium, and they're associated with one of the largest health plans in the United States. That is unacceptable. So what's going to happen is that we're going to continue to partner with the 28,000 people who have said yes to the clear pricing. Once again, some of those providers are going to make less money, but they're tired of this. Now, I just want to say, in an effort to kind of bring up the temperature a little bit, this whole thing about transparency, you could send this list back to me tomorrow if you like. You don't need a document. You don't need the approval of this audience. If you want us to know the prices of what we're supposed to pay on behalf of these employees, just send this document back to me tomorrow with the prices on it. Secondly, you've heard about a lot of anxiety about access to health care, but yet you've just heard 2 examples of narrowing people's access to health care so that one entity would get all the business. And the other thing, which is shocking to me every time I hear it, the great example you gave of the person who visited the emergency room, what was it about all those previous visits where the right thing didn't occur then? Why do you need a new plan, a new slogan, a new whatever to compensate people to do what they were supposed to do the whole 30 other times that person visited? And lastly, I don't know, maybe Dr. Ewing would like to answer this, but do you pay family premiums? I know you said you had family on the plan. Do you actually pay them? It actually comes out of your check like it does everybody else in this room. So unlike my paycheck, my pay stub, it actually has a deduction for my family premium. Does that happen for you? Yes. Okay.
So we have in the School of Medicine healthcare as one of the benefits that we provide folks. I think, you know, other places provide different benefits. You all know from working at UNC that we don't always pay the highest faculty salaries or staff salaries, but we do try to work with some of the other benefits. I'd love to answer a couple of your other questions. The poor woman who went to the emergency room, the problem for her, right, is the emergency room is not set up to provide behavioral health care. If any of you have been in our emergency room here, you see how difficult it is to care for those folks because we don't have them in the right place. So the right care at the right time by the right provider in a convenient way, that's what brought the cost down for that patient. When a patient comes in the emergency room, it's mostly about making sure that there isn't an emergency that can't be solved in an outpatient setting. So getting that patient onto the right plan is what really transformed her health, and so we're very proud of that. The other thing is we're going to have to make decisions about how we're going to fund this, and you mentioned narrowing networks. One way to help control cost is to narrow networks. I'm not saying that we all should choose that or have to, but at some point we're going to have to, I think Aaron was making this point, we're going to have to make tough decisions about whether we want total freedom of choice or whether we're willing to accept a smaller freedom of choice in order to bring costs down. It doesn't mean quality has to drop. And in fact, all of these value ideas that we're talking about are tightly tied to measuring quality and outcomes. And in nearly every one of these models, the reimbursement is tied to the ability to meet quality metrics. When we were asked sort of what the next year looks like, we're working with the state. The legislature approved the Medicaid program, and we're working through the DHHS to create Medicaid contexts that are based on volume. We're working with the federal government, CMS, to take care of seniors who are on Medicare through a program that involves value. We're working with private companies, we're working with private insurers. So all of these efforts are going in the same direction, and there's a tremendous synergy in our system, in the Duke system, and other systems where the same folks who are making a phone call to someone who's on the Medicare program and is having behavioral health programs can hang up the phone, call somebody on the state health plan. Then they can hang up and call somebody who's on Medicaid, and we can build that synergy so that all of these things are rowing in the same direction. And if we have one really important plan in the state that's going in a totally different direction that most of the major providers in the state have not thought was the right direction for healthcare, then it's really hard to get synergy and to bring costs down.
All right, thank you. We're getting several questions that are sort of following the exact same train. So I'm just going to condense a few of these questions that are coming online. You can see some of them up here and down here. So one of the things that the people are asking about is talking about this total health or preventative health. It seems as though a lot of the benefits for some of that preventative health have been removed from the plan over time. So one of the particular questions was talking about the stroke rewards program, the diabetes prevention program. So is there a thought to incentivize, again, basically good health in order to help lower the costs in the system? I know it sounds like we've had parenthetical pieces of that discussion already, but as a way to reduce costs, making people healthier so they use less healthcare and building those pieces into the system. And I apologize for those folks on Zoom, trying to condense a few of your questions together. I hope I covered what you were asking.
Everybody's in favor of having a more healthy workforce. The fact is that your plan, according to this report, this is why I carry all this stuff around, tells you that over the last 6 years, your state health plan has spent $168, not $1,000, $1 million on population health management, on some of the programs that you just mentioned. And in many instances, not all instances, it was shown that the return on that $168 million worth of spend did not bring any value to either the participants or the plan itself. You can't cut the cost of anything until you know what it costs. None of you would go to Harris Teeter where there was no prices on the aisle, and then when you got to the checkout, you were asked to give a credit card, and then 5 months later, you got something in the mail called an explanation of benefit that didn't explain the benefit of anything.
But moving back to the question, which was about the preventative programs.
The preventative programs are very simple. Anything that brings value to our participants or our plan, we consider. But as we started looking at these programs, and this is the previous administration who brought some of these programs to our attention that needed to be eliminated, we didn't see the value. For example, smoking cessation. The smoking cessation is planned. That's a preventative thing in line with your question. Okay. We found some of the smoking cessation materials on eBay, because what would happen is that you would say, yes, I smoke. Yes, I agree to cessation. All this stuff would show up on your front porch. I've never consumed any of it. I guess it's patches, lozenges, and something else. It would show up on your porch. You would get a credit on your state health plan. Then the stuff would end up on eBay where people were trying to sell it. This is really happening. I know people get frustrated with these little examples, but this is really what's happening inside your plan. So now we have put the smoking cessation with our Minute Clinic relationship so that people can actually go in and prove that they're trying to do something to stop smoking. That's an example of figuring out what's right, getting it right, and keeping it right on behalf of the plan members around one area called smoking cessation.
Right, excellent. So anyone else have a comment on this particular piece, the prevention?
So we're strong believers that every patient should have a primary care doctor that they can identify who's I sometimes tell my patients, right, your health is a ship. You're the owner. Your ship needs a captain. The captain works for you. Your primary care doctor is the captain of your ship. And so I hope everybody in this room, if you take nothing else home with you today, you should have a primary care doctor. And then we need a system that encourages our primary care doctors to monitor our health and not just deal with the problem that's immediately in front of them. And so the approach that we're describing encourages and provides tools and the resources needed for our primary care doctors to watch over us. And so I'll just give you a very practical example of that. In our faculty practices for our primary care doctors, we've started a plan where those folks, their compensation now is not based on how many people they see, or how many visits they have, or how many clicks they make in the electronic medical record. It's based on having a population of people that they're responsible for and keeping those people well. And then we have infrastructure with pharmacists and social workers and nurses and many other folks. We have paramedics who go into people's homes to make sure that they're using their incentives barometer correctly. We have a program where we find the people who are most likely to end up in the emergency room on Saturday. And so we call them on Thursday for a tuck-in call, and we say, how are you doing? Do you have your meds? Do you need to see your doctor tomorrow, Friday? So we can keep them out of the emergency rooms over the weekend. So we have to build into the system and support, and I know the state health plan would support this, build in the system so that we're really pushing preventative care to the front of what we do and keeping people well. Smoking is a bad thing, and so anything that we can do constructively to discourage people from smoking is good. The primary care doctor, the captain of the ship, has to be involved in that process, right? That's the primary health advisor on the medical side for most patients.
Thank you. We've got a question actually for Shayna that came forward. Do you have a minute? We'll take 1 second. It came through. One question that came through Zoom, and then we're going to start in the audience. Does that sound okay?
Sure.
That's what we will do. Shayna, this person just asked for you to, if you could, speak to this person's characterization of, it seems as though we are definitely, as they described it, an us versus them mentality about this particular issue that seems discouraging as you listen to some of the panel today. As a staff liaison, staff representative, the employee forum representative, what would you say to that?
So I will preface my remarks by saying I don't think we are unique. I think that the conversation countrywide is complicated and people are having these discussions everywhere. What I do hope is that we can stop the divide and start thinking constructively towards how can we bridge the gap between what seems to be two very different sides of the problem. People can't afford the insurance that they have. People are not opting to go to their primary care physician because that just goes to the bottom of the priority list. People are not opting to use the care that's available to them because they cannot afford it. And so it's a lofty goal to become that person that checks in with your primary provider and does all of the things to keep yourself healthy. But if the choice is your family's health or yours, and you choose your family's health, then that's where we are. So these aren't options that we can even tap into. And as staff, I'm delighted that faculty have that as a benefit, but staff do not. And when I talk to staff about their healthcare premiums for their families, it is absolutely unaffordable. Their salaries cannot support this. And I'm talking about people who come in and really work to the best of their ability to give every effort that they have. We talk about all the changes happening and being nimble and new technologies, and these people are doing their very best to make all of this happen, and they can't stay healthy. This is not sustainable. So if we do have this us versus them mentality, every single person in this room can start to break that down. Talk to each other. We have the brain power. Look around. We are amazing human beings, and we can fix this. But if we get caught in this, oh, you said this, or you did that, or you boycotted, or you didn't boycott, that's not getting us anywhere. And people are caught in the middle. And these are human beings. We're not data points.
Let's start our questions from the audience. And if you have a specific panelist you'd like to address a question, that's fine. If not, it'll just go to the general panel.
I think this question may be going towards Dale Falwell. Thanks to each of the panelists. I do have a question, and that is, it's my understanding that hospitals must indicate their prices so that, you know, that the cost is compared, and how's that going to impact clear pricing in the future?
Thank you. I'm not sure exactly what you're referring to, but there's actually been laws on the book, both federal and state, for a long period of time that show that these prices should be transparent. Now, there's a new directive from the president on healthcare transparency, and talks about the opaque pricing of healthcare, and it's meant to reward the big insurance companies and large special interest groups. We're all seeing that. This is coming from all sides. And my point of saying that to you is that it doesn't matter who says it, it's not happening. When I asked the hospital association, the director of the hospital association, who's charged one of the largest hospitals in North Carolina, would he consent to us telling people of Eastern North Carolina, for example, how much he had gone up on their health care cost for state employees? The letter back to me was, I do not consent. So every time that we try to figure out what we're supposed to pay, we know what we're being charged. We're trying to figure out what we're supposed to pay. Every time we figure out what we're supposed to pay, it's these fingers that keep pointing at each other. And every time that happens, the people, as far as the two sides are concerned, our loyalty and our duty of care is only to the participants, the members of this plan. It's not to big healthcare, big pharma, and the pension side. It's not to Wall Street. That's who our loyalty and duty of care is. The fact is, the Clear Pricing Project allowed everybody to know what things cost, and we're going to pay them a substantial profit over what the Medicare reimbursement rates. This is where we're going to start. That's not the end. Then we're going to go to bundles. You know, just 80 miles from here, possibly in Pinehurst, you can get a knee replacement for about $19,000 bucks. At UNC Healthcare, don't hold me to these numbers, let's say it's about 28,000 bucks. At Duke, it might be 37,000 bucks. The fact is, nobody knows what anything costs. And going back to the earlier comment, because I was in this situation for most of my life, a third of my life, when you're sick, it'll make you poor. And when you're poor, you're likely to get sick. You know why? Because you're working two jobs. Because you work sleeping 5 hours a night. Because you're busting your tail so that you don't have to make the choice between family premiums, which some people aren't paying, but the people that serve the people that aren't paying it are paying the family premiums. that needs to end tomorrow. But the fact is that you can't cut the cost of something till you know what it costs. And that's all the clear pricing is meant to do, is to give transparency to the consumer. Because I trust all of you who I've never met personally, most of you. If I put the power in your hands to consume something, you'll figure out where the value and the cost is, and that's going to help everybody.
All right, thank you. Next question.
I'm curious that one of the questions that has not come up is why the many of the institutions, including some of our best healthcare institutions, have resisted the Clear Pricing Project. And I wonder whether one of the real reasons may be that they have higher costs for uncompensated care that are being subsidized by those with premiums, that they need money for research, and that they're dealing with more complex, they're tertiary care research hospitals that are dealing with the most complex situations. And so those are not equal statistics across the state.
We would like to take that on the panel.
Well, there are some hospitals across North Carolina that stood to make millions more money. More. And they did not sign the contract because they don't want to get away from secret contracts. We offered them, because of the reimbursement rates, they were going to make millions more in reimbursements. And they still didn't sign the contract. So that tells you that these cartel-like activities, and for those, Webster says a cartel is an association that is formed to restrict competition or raise prices.
So moving back to the question itself.
I think when I talk to colleagues of other institutions, I talk to them about patients that we share. We're not talking about reimbursement for this, but I think it's the fear that doing this in this manner will be destabilizing to the healthcare system, that it will lead to closure of rural hospitals, that it will, as I said at the beginning, we do close to $500 million of uncompensated care for folks. Those aren't folks who are on the state health plan, but our mission is to all the people of North Carolina, and a sudden race to a plan that may be able to be improved before it's implemented, it takes a real risk of destabilizing our healthcare system, and meaning that none of us will have the access that we want. And if there's no access, it doesn't really matter what it costs if you can't get in. So I would love to see, this state is really at the center of healthcare change in America, and the eyes of the country are upon us. We have such smart people. We have Dr. McKeithen and the group at Duke. We have our wonderful School of Public Health here. We have leaders in the various systems across the state. We could pull that group together with the state health plan on very short notice and start the hard talk that you all want us to have about what's the best system, and let's get it in place. What things are already going on that we can build on? We don't have to reinvent it. What new changes do we need to make? And I will tell you, the UNC healthcare team is ready to meet this afternoon or tomorrow or the next day to really talk about how we do this. I heard everything you said. It's very powerful. We've got to get the cost down, and we've got to reach an agreement on the best way to do that, and then get going and do it.
All right, other comments? All right, next question.
Hi. I'm actually 3 weeks out of surgery at UNC, so I have a very personal kind of knowledge of it right now. Mr. Foley, I was dubious at first. I'm a fan now, so you have turned me. I have a question though. You are UNC hospitals. You are on state property. Why did you even get a choice to say no to being included in this when you are a state in every way, shape, or form school? I mean, you're basically owned by the state. Why did you have a choice at all? You should have been incorporated and already working with them on how to show this. I can give Mr. Falwell my hospital bill. You can have all the detail of it. There's a $13 Motrin. Why? So there's a lot of explaining to me that you guys need to do as just UNC as to how you're not automatically working with the state on this clear pricing. I could see Duke saying no. Duke is incorporated. My husband works there. For a $40,000 surgery cost us $635. That's all we paid. Mine, of course, I had to do the $5,000 copay. But saying you want to meet right now makes absolutely no sense when you should have had no choice at all.
All right, so
you're supported by.
Let's hear an answer to that. Please, go ahead.
Thank you. First of all, I'm thrilled to see you doing so well 3 weeks out. So that's good news. I hope your recovery is quick. we would love to partner with the treasurer. We do see a special bond as a state's healthcare system, but our arm of it does not report to Treasurer Falwell, and so our fundamental responsibility is to our mission and to the people that we serve. It's our patients, and this plan would be very, very bad for the patients that we take care of. And so we would like to meet, and we were ready to meet 6 months ago. We sent our plan in. We've not yet been able to get a response about, I can't believe in a 6-page plan there isn't a single thing that would be worthy of discussion. We would love to do that. And so I can understand your question, but Treasurer Fowler can't come in here and say, shut this room down and let's turn it into a cafeteria. It doesn't run this part. The state health plan is pretty complicated, right? I mean, we don't have a contract with the treasurer, right? The state health plan picks a company, in this case, at this time it's Blue Cross, and they contract with Blue Cross, and then Blue Cross goes out and contracts with Duke and with Atrium and with private docs. And so we wondered when we got the request, why don't you just get the information from Blue Cross? That's who your primary person is in all this. We would love to work with the treasurer, but we've got to understand where we're going with all this and make sure that it doesn't cripple our ability to take care of the people in the state who need us, to continue the education that we do, to continue the research that we do. Those are the things that get us out of bed and drive us and help us decide what to do. So thank you for your question. I'm glad you're doing well.
Right, next question.
Hey, thank you so much for being here. So Treasurer Falwell, I too am enjoying your apparent empathy for our, I'm in the English department, so I'm a full professor and I'm the director of graduate studies, and I think I make probably like, I don't know, 20% of what people in the medical school make. And our health care is different. We have a different tier, so it's not as good. We pay more for less care. So I really appreciate the empathy. And my question to you, though, is what was scary to me, and I think probably a lot of people here, is, you know, great transparency seems, I don't understand the problem with that. But I am worried a little bit about the clear pricing, or what's it called, clear pricing, because I worry that it's kind of like, well, you hospitals participate, or else, you know, the people who go to these doctors here are just going to end up paying more. So, because they don't have any obligation if they don't participate in clear pricing to come down in price. We still take, my daughter's getting older, she has allergy shots now. What, am I just going to get a bill one day that I can't afford to pay that? You know, and under your proposal, I really appreciate, I honestly do, the sort of, you know, attempt to make hospital executives make things more transparent. But I'm a little worried that the way that it's set up is not protecting the consumers, as you're calling us, right? The buyers aren't protecting the consumers in this case. You're kind of going, I dare you to not do it, and then if it doesn't work out, too bad for the English professors and the staff.
Number one, that obviously wasn't the intent. The intent was that we have enough medical needs, we have enough medical providers, and we have enough billions of dollars that we thought by offering an average of 100% profit, that everybody would be in network. So that would have addressed every concern that you have. The fact is that we didn't start at 100% profit. We started at a reimbursement rate of 172, then we raised it to 186. Every time that we raised the profit, every time, we were met with more attacks. For example, we raised the profit for rural hospitals so that they could remain independent, and their association said, there the treasurer goes throwing more money after a bankrupt system. You can't sit on a stage and say that you're advocating for rural hospitals, and then when you put more money toward rural hospitals, then you're accused of throwing more money after a bankrupt system. You're just in a vortex. So what we're referring to right now, and you're starting to see some TV commercials about this already, is about balanced billing. In the state of Virginia, I believe, they have something called Hospital Day. Hospital Day is a day that's set aside in the court system for people who are having liens on their property or having to file bankruptcy because of medical bills they don't understand. So this whole realm about all this is obviously very important, but you can't cut the cost of something and you can't figure out the value of something unless you know what it costs to start with. That was the basis of clear pricing. Never to be out of network, never to have these hospitals say, we're not going to serve even the people that work for them.
All for that pressure that you're
Good.
putting on the hospitals. But I do hope that you'll also protect us so that we don't, as you're saying, get caught in the middle. And I understand that's what you guys are doing. Yeah.
As you can probably see by my demeanor, I'm a pretty protective person. Thank you.
All right, thank you. Next question, I believe in the back. Here, where's the next?
Hi, thanks all for coming. So Dr. McKeithen stated that reducing coverage for certain procedures and treatments would not be the way to solve the healthcare debate. However, I have a question for Treasurer Falwell to address exclusions that he's publicly spoke about. Gender dysphoria is considered a serious medical condition per the American Medical Association. The DSM-5 and majority of medical providers show evidence that gender dysphoria requires medically necessary treatment that is often life-saving. Additionally, we know from a 2018 ruling by the U.S. District Judge William Conley that the exclusion of this coverage violates federal anti-discrimination laws, as well as has the potential to only cost a mere 5 to 10 cents per month per member to cover. Will you reconsider your exclusion of coverage for transgender people? And if not, what resources or literature inform your decision not to do so?
As you very well know, we are currently the defendant on a court case that involves the very things that you're talking about. And it's in federal court, and so I will not be commenting on that. Gender dysphoria, otherwise known as sex change operations, are an issue that's debated all across the state and all across this country. The state health plan has a responsibility to deal with all types of procedures. We don't cover every procedure. But at the end of the day, what I've said publicly, which I'll restate today, until the courts, the legislature, or the voters tell me when and how to pay for this surgery, then I will. But currently, we're a defendant on a lawsuit regarding this, and I'm sure that the courts will deal with this. Thank you.
In the back.
There has been, in the context of global supply chains, is there any more revisiting of allowing us to purchase drugs from other countries for and be reimbursed for the state health plan?
I love the question.
Yeah.
So I was just conversing with the treasurer of Utah. Utah is not considered it's a wonderful place and a wonderful state. The state of Utah this week is flying people to Tijuana to buy prescription drugs because they can fly people out of Salt Lake City to Tijuana and get drugs cheaper than they can in Salt Lake City. This is really happening. And the fact is that we're spending about $1 billion a year money on prescription drugs. So in case I run out of time, I'm going to tell you from this point forward, you should never buy a prescription drug again unless you ask the pharmacist, what's the cash price for this? You might find out that the cash price for a prescription drug is less than the price could be by using the state health plan card. That's an example of pushing the power to the consumer. Our drug costs are too high. As a matter of fact, where I was looking forward to going with the clear pricing project, back to the earlier question, because we have enough money, we have enough needs, we have enough providers, we were going to get transparent healthcare costs. I was looking forward to partnering with the hospital because a big part of the hospital's spend is on prescription drugs. So it's not just a cost that we're absorbing in the state health plan through a pharmaceutical benefit, it's also a cost that the hospitals themselves are absorbing internally. So I am totally in favor of every aspect of your question, and I can tell you it's gotten so bizarre that the state of Utah, for some high usage and high specialty drugs, are actually flying people to Tijuana, Mexico to buy their prescription drugs because they can do it cheaper. There's no excuse for that, especially with a plan of our size.
Next question.
Thank you. Shana, you made a comment earlier that I thought was really great about the idea of removing these barriers. and breaking down obstacles to finding solutions. And it made me think of it basically a two-part question. I don't know if you want to take this, or Mr. Brody, if you'd like to take this. But first part of the question would be, we got a lot of folks in this room that work for the university system or work for UNC Healthcare. Are they or are they not prohibited from engaging in political activities while they are on state time?
Yes, while you're on state time, you are not permitted to engage in political activities. When you are off, off duty, your First Amendment rights in terms of petitioning your elected representatives and so forth, absolutely appropriate. And to that end, let me make a comment on something you said earlier about folks being discouraged that, it's sort of us against them and so forth. I can tell you, our colleague from UNC Healthcare, they serve 1.4 million patients. I don't remember whether it was 14 hospitals or 12, but 500 million in charity care, 40 million to the School of Medicine. It's a very difficult balancing act to run a large healthcare system and to meet all of the public obligations that they do. The gentleman to my right runs a healthcare plan with, 750,000 people, very challenged in terms of the level of funding that they're apportioned by the state. They have to balance the books every year in terms of running the healthcare. Another very difficult job. Very different responsibilities, but I'm quite convinced them and their colleagues take it quite seriously. I don't think this is a demonstration of us versus them. I think there are systemic challenges in the healthcare delivery system and in the insurance industry that are a lot bigger than the people on the stage, that are a lot bigger than the state health plan. And I think part of that, and this gets to your point, which is why I'm saying this, we have elected representatives in Raleigh who have a role in this. We have elected representatives in Washington who have a role in this. Quite honestly, both of these gentlemen are subject to a lot of the design of the system that we currently have in our country. So I certainly don't discourage anyone from going to their elected representatives and saying, part of the reason dependent coverage is large, that ties to the employer contribution. There are other employers who have equally costly health plans, which are not paying the same level for dependent costs because the employer is paying more of that. Many of these employers, the employees pay more for individual care than we're paying. So I don't view this as an us versus them, not to minimize the serious challenges. I think we've got a lot of good people who are really dealing with a very imperfect system that needs reform at a much higher level. But I do think, and I come back to your point, good people trying to solve a difficult problem, but we, meaning the employees of the university, cannot be up at night worrying in 6 months whether we're going to be a network. And no one wants to see that, including, I know, Treasurer Falwell. So anyway,
Second half of that question, though, would be directed at Dr. Ewan. Oh, I'm sorry, Shannon.
I would not be doing my job up here if I didn't point out that, and I cannot quote the numbers, but staff are graduating hundreds of thousands of people across the state. So we are hardworking as well and working within a very difficult, challenging system. And the second thing I wanted to say is it just seems deflating to me that we are talking about healthcare as a political issue. I just wanted to make that comment.
I couldn't agree with you more. And that's why the second half of my question, then, given those facts, is for Dr. Ewan. Given those facts, why then, since you're the representative of UNC Healthcare and UNC Physicians, why then did UNC Healthcare expend $58,633 this year to help fund a dark money political group that was solely formed to defeat politically the clear pricing project? Can you answer that question?
Yeah, I'd be glad to answer it. We didn't. We did submit our dues for the North Carolina Hospital Association, and there was a line item for a special project. We misinterpreted what that was, and as soon as we realized what it was, we got our funds back, and our money was not used for that. So excuse us for the accounting error, but it was not intentional, and we didn't use our money for that. I did want to note that it was at 129 that I was clear that I finally had something I was in deep agreement with the treasurer about, and that's that pharmaceutical costs are too high, and a lot of what's driving the problems that we all face up here on the stage is that the drug costs are going up 8, 10, 12% per year, and none of us have the ability to cover that. We would love to take the treasurer up on the offer he made today to partner with him. There are ways that the UNC pharmacy could take some of the work and other pharmacies from the big systems across the state. Right now, if you have a brain tumor and you need the chemotherapy temozolomide, which is the drug that we give to folks with bad brain tumors, or if you get hepatitis C and you need to be cured and get one of the drug combinations, that's going to CVS, which is a company based in Rhode Island, and their fundamental responsibility is to return a dividend to their shareholders, and our responsibility is to take care of the people in North Carolina. So we could partner on that and probably try to curb that drug cost. It'd be a great example of working together, and maybe out of this forum will come the opportunity to restart that discussion.
Yeah. Hi, my name is Katie. You might have noticed by my wheelchair that I have a pre-existing condition, so healthcare is obviously important to me. I'm on faculty here at UNC. I had actually had to have some neurosurgery earlier this year, and so in the last 12 months, I've had more medical bills than expendable income. I mean, I'm thankful to have insurance, but the reality of everything you've been talking about is definitely personal to me. I'm on a yearly contract, and so in May, I decide whether, my boss and I sit down if we're going to be here from July to the following June. If open enrollment isn't until November, my two questions are, one, as it stands, what is 2021 going to look like? And number two, when are we going to know what that's going to look like? Because if I have to wait until November of 2020 to know whether our healthcare is going to be slashed or not, I mean, that's too late for me to find a new job, or, if our coverage gets slashed at all, I can't afford that. So I would have to potentially find a new job. So when is the expectation that we as employees can know what you guys end up deciding? What is the deadline for that? And as it stands now, what is 2021 going to look like and beyond? But
More transparency, more control back into the consumer hands, and lower cost. That's what it looks like from us at the state health plan.
is that a decrease in like I had my neurosurgery at Duke. I tried to go into UNC and didn't get the care I needed. I went to Duke. Does that mean like that hospitals that don't approve or participate in the clear transparency plan, they're not going to be eligible for us? Or what does that mean bottom line for me for my healthcare needs?
Well, number one, according to Dr. Burks, about 50% of UNC employees actually go somewhere else for their health care. That's a statistic that he gave me in the presence of about 10 other people, including Board of Trustee members. What that means is that for next year, as you know, all those options are exactly where they were last year. We're going to continue to drive forward to get rid of secret contracts, give the power to the consumer, and lower the cost, because that's what our responsibility is. We have a loyal and duty of care to everybody in this room and everybody on this plan. And we're going to continue to fulfill that very, very strongly.
Thank you.
So I'll just add briefly to that. I mean, since this issue developed, the UNC Staff Assembly, which is composed of the employee forums or staff senates of all 17 institutions, has been very concerned about this issue, has asked me reliably, like every week, what's going to happen. I have no magic ball. Certainly, the treasurer and these folks know more than I do. But and there are no guarantees in life. But one thing I said to the staff assembly, I'm pretty confident that by the time we get to December, rolling into the new year when this would take effect, that 3/4 of the hospitals and doctors in North Carolina wouldn't be out of network or 750,000 people. I had no guarantee of that, but I said, wait until December. I predicted it would probably be a last minute kind of a fix. It turned out it came earlier, which I'm very grateful for. There are no guarantees, but I do not see that we're going to reach the end of next year and somehow, 3/4 of the major health systems in the state of North Carolina are not going to be a network for, 720,000 people. So I'm optimistic. I've told folks not to panic. I would say the same for next year. But obviously, we'll have to keep our eyes closely on this issue and advocate very strongly in the same way that you did earlier. We all want to be part of the solution, but we don't want to be disproportionately affected. And I don't think ultimately that we will.
We won't
I'm
know
gonna
about
try to
20
get to some questions quickly. Yes, over here.
Good afternoon. Thank you. My name is Todd Hucks. I've been a employee here for 25 years, and I have dealt with UNC family practice. And I can tell you one of the things you were talking about, having a personal physician or a primary care physician. My only problem with that is every 6 months after I go, it's a new primary care physician. So I don't see the same person once again. So I have no history with them. So it's hard for me to develop a repertoire with the doctor that I'm trying to see. Longevity here might account for something. I would feel better about it. The other thing is when I get billed through UNC hospitals, which even if I have an MRI done off of it, off campus or off site, I'm still being charged. So now I have to fight with the insurance companies, which is a once a week deal. And you talk about getting your blood pressure up about something. So not only, I mean, you talk about having a primary care physician, but that's good. But then also being billed wrong or being billed more or because we're going through somebody we already deal with. So that makes it even harder. So if you want to help us out there, try to fix that. And also, how do we get rid of, or do we have any more secret or no bid contracts anymore?
Yes, we're trying to get rid of those. And that's the purpose of doing this. What you just described doesn't come from me. It comes from the United States Institute of Medicine, who talks about the inefficiencies of healthcare. These are the 6 pillars of the inefficiencies of healthcare. There's a minimum of 12 to 15% savings in the healthcare system by just doing it better. And there's all kinds of reports that talk about that. And so that's where our focus has been.
Say it that way, but you're going to lose your existing patients because they lose patients with dealing either with billing or with not being able to see the same doctor anywhere close to,
I appreciate your thoughtful words. We obviously want your experience to be really sound with your doctor and to have you have a sense of longevity. I'm happy to talk to you about it afterwards if there's something we can do to help. It is complicated, isn't it? This whole system, I mean, the treasurer did not invent it. I did not invent it. None of you invented it, but we have this very complicated healthcare system and we are all striving to get value. Remember, value is not a code word for money. Value is the best possible outcome for your patient for the least amount of money that you have to spend to get that great outcome. We'll be careful not to make our whole discussion today solely just about money. It's about people. It's about wellness. It's about getting the surgery you need or seeing the primary care doctor you want to see. We'd like to make it easier and make it so that if you get a bill at home, you can understand what it is and why you're being charged.
I hate to say this, it is 1:44. If you panel doesn't mind, we'll take one more question, and then I want to be respectful of people's time that are here today. One more question. I'll let the folks with the mics.
I just have a comment about, along with all of this, if we do clear pricing, there has to be a way to help people be better consumers. I'm in radiology, so a CT scan is not a CT scan is not a CT scan. So I had a colleague that shopped around. She did this clear pricing thing. So she called UNC and got the price for her CT. She called Duke, got the price. She called some outside outpatient centers, and she found a CT scan that cost $700, which was less than what her out-of-pocket was going to be if she got it done at Duke or UNC. So she went there and got it done. It was done on a piece of equipment that was over 15 years old, and it was a useless CT. So she then was out the $700 out of her pocket and then had to go have the CT done somewhere else and pay the copay. So some of this is making sure that when we go here, it sounds good, but let's make sure we help consumers be good consumers. It's not necessarily you get what you pay for, as Dr. Ewan said. Value and money do not always equate in healthcare. But you started with the beginning. It's when we take a credit card and we buy something now, we know what we're buying. That is not a direct correlate in healthcare, because getting an appendectomy here and getting an appendectomy somewhere else may not be the same level of care.
Excellent.
Just be
Thank
careful.
you. That is a wonderful spot for us to stop. Look what's happened today, though. I want to take 1 second and say that this needs to be the first of many conversations that we have as a group about this. I think that we also, as employees, have a responsibility to take our place at the table in these discussions. And I will say, we as the Employee Forum can provide a way to do that. That's what our job is. And I will say, I feel like somewhat that we have been a bit remiss in that, in taking our seat at the table strongly. So let's make this the first step that we're taking to take our place in these discussions going forward. So watch this space for more information as we move forward. Thank you so much to all of our presenters and panelists. We appreciate everyone being here. Have a wonderful day. You folks that are on Zoom and you have questions, there is not going to be an unanswered question on Zoom. My commitment to the questions that you've gotten here is they are going to be answered. Some of them are multiples of process questions, so it's a relatively simple fix. But I want you all to get your answers. Thank you. All right. I need to get these questions saved.
I think Phil just